there, I assume it's there. Okay, so what we're going to do is these are just standard cases. You'll get a case, you'll get a cardiogram, and you'll get some questions, and then we'll give you some answers. This is almost always just straight ECG interpretation. So we have a 9-year-old boy who's admitted to the ICU after a bicycle accident. He has a history of congenital heart disease corrected by surgery. His ECG is shown, and there's his ECG. And the question is he losing ventricular capture? Does he have normal DDDR pacing? Is he atrially oversensing? Does he have normal atrial pacing? Or is this a pacemaker-mediated tachycardia? We probably have to give about 15 or 20 seconds. This is not, you have to look at the tracing. It's not something they're going to be able to get first. Yeah. Okay, we can start the clock now. Yeah. Whoops. Okay. Want to start the music? Or, whoops, there. Okay, so we'll start the music. Good. So we're supposed to change partners now? Okay. They have a problem. Is it fixable, or should I just keep going? Okay. Well, this is normal AAIR pacing. And the issue here, again, is you have to identify what's atrial activity and what's ventricular activity. And what you always have to be careful about is being fooled by something that looks like ventricular activity. And if you look in V1, boy, that looks like a QRS. But actually, if you look down, you'll see that that's actually the P wave. So this is a boy who had some heart surgery and has a giant atrial activity or a giant P wave when he's atrially paced. And then his QRS in the same lead is normal or is smaller. But if you look over here, if I gave you just lead 1, you'd pick it up. This is a P wave, that looks like a QRS. So you always have to use the cardiogram, use all the information, not be fooled by what catches your eye first, and recognize how the cardiogram is recorded with everything just being coming up there like that. So that's normal AAI pacing. It's not dual chamber pacing. There's no pacing spike associated with the QRS complex. And this is just straight AAIR pacing. And here you can see that these are atrial spikes, and over here you identify that they're atrial spikes. But over here you have to identify that even though the signal is very large, that's still an atrial signal. And if you track it down with the simultaneous ECG recordings, it becomes easier to see that. So straight AAIR pacing. That fools almost every cardiology fellow for 10 years, and they never get that right. Okay. A 39-year-old woman has a history of paroxysmal atrial fibrillation, and, okay, I guess you're supposed to, maybe you have to reboot, so they're asking you to log in your ID number and then press send. So everybody should log in their number again? Okay, it's the numbers on your badge if you've forgotten, so just log those in, and then we can get going again. Okay, so this is a 39-year-old woman with a history of paroxysmal atrial fibrillation. She's on propafenone, which is a Class 1C antiarrhythmic drug. She undergoes an exercise test to evaluate exertional chest pressure and develops a tachycardia. Her ECG is shown. Her blood pressure is now stable at 100/60, and she has mild chest pressure. And I want you to tell me how to treat this ECG. So, okay. So this is the ECG, and should you give her magnesium, amiodarone, metoprolol, cardioverter, hypertonics, sodium chloride, or adenosine? And again, we have to let people look at the tracing for about 30 seconds. Okay, now we can start the timer. Put your answers in. So remember, this is not a 12 lead. This is leads 2, V1, and V5, as you can see. Well, a third of you got that correct, or almost a third. So let's look at what the rhythm is. The first thing is to decide what the rhythm is. And remember, we have there's a lot going on the tracing. We have, at the end of the rhythm, we have a narrow complex tachycardia. We then have some intermittently narrow beats and then wide complex beats with two different morphologies. And then we have some more narrow complex tachycardias. We also can see, if we look up in lead 2, that this is atrial flutter. Okay, see, those are flutter waves. And they actually march through. And what we're then seeing is we're seeing periods of variable AV conduction and then a period of one-to-one conduction, because the rate out here is the same rate as the flutter waves. And we also know that she's on propafenone. And propafenone is a drug which this is its major toxicity. It can take atrial fibrillation and convert it to atrial flutter, and it delays conduction in the His-Purkinje system. So alternating bundle branch block, which is what this is. This is both right and left bundle branch block occurring alternately before it goes to one-to-one conduction. So this is the classic atrial proarrhythmia seen with propafenone. So if you see a question that says propafenone, you think of what's the toxicity of that and what you do it. So if we go through the answers, well, magnesium would be right if you thought this was Torsade, but it's not Torsade. Amiodarone would be right if you thought this was a ventricular arrhythmia, but it's not a ventricular arrhythmia. Metoprolol, DC cardioversion, isn't wrong, except that, remember, I've told you now she's comfortable, has pretty mild chest discomfort, and has a blood pressure that's good, so you probably wouldn't want a cardioverter acutely. Hypertonic saline would be okay if you thought this was really VT associated with an antiarrhythmic drug. And adenosine, you already have a period of AV block, and adenosine's not going to stop it. Metoprolol will get you from going 1 to 1 and probably get you to go 2 to 1. That'll take her symptoms away and hopefully allow the arrhythmia to terminate. So there's lots of questions there, but the thing is, look at the stem of the question. Propafenone, atrial fibrillation. What happens to people with propafenone as atrial fibrillation that are bad? They go to atrial flutter, and they can conduct rapidly. So those are the things to think of, and that's the answer there. So I think I have, just to show you that that's what this is, notice I've marked the flutter waves, and you can see we have some left bundle here, we have some right bundle here, and then it goes 1-to-1 conduction. Notice that the flutter waves have a cycle length of 270 milliseconds, and when it's 1-to-1, it's a cycle length of 270 milliseconds. So you have to recognize all the things to put it all together. Dr. Perlo just asked, well, how would you treat flutter? Well, metoprolol won't convert the flutter, but what you're really worried about in that situation is the 1-to-1 conduction, and then you can start treating the flutter. So the first step in somebody with very rapid rates in flutter is to try to get rid of the rapid rates. Then you can worry about getting rid of the flutter. And in fact, when it's exercise-related and paroxysmal like this, it often will just go away by itself. Okay, a 79-year-old woman presents with increasing dyspnea over the last 8 days. She has a history of a mitral valve replacement with a St. Jude mitral prosthesis. Her only current medication is warfarin. Her ECG is shown. And the question is, what is the arrhythmia? Is it AV node reentry, ventricular tachycardia, atrial fibrillation, atrial tachycardia, or sinus rhythm? So let's wait about 30 seconds, and then we can start the clock. Okay, we can start the clock. Ooh. Okay. Well, 8.3% of you got this right. First of all, remember what I said. Let's go back to the question. Mitral valve disease, status post-MVR, on no other medication. So this is somebody who has atrial disease, right? So we're going to think about atrial arrhythmias. Then what type of arrhythmias do people with mitral valve disease get? They get atrial fibrillation, they get atrial flutter. They can also get very slow forms of atrial flutter, which fall in the range of atrial tachycardia. So your next thing is to look at the cardia. So that's what you should be thinking when you do it. People with mitral valve disease don't suddenly develop AV node reentry. They don't suddenly develop, then the question is it sinus rhythm or not? Okay, so then we look at it. The QRS morphology is sort of an incomplete right bundle branch block. Remember, you can get very wide, very sort of funny-looking QRSs in valve disease. So it's a sort of an incomplete right bundle branch block. But I think most people would say it's probably narrow. It's not a full right bundle branch block. There's a lot of ST segment depression and elevation. This actually was her chronic pattern, and that's for the rhythm diagnosis, it's irrelevant. The rate is about 95 beats per minute. And then the question is, can we identify normal P waves? Is this 1-to-1 or is this 2-to-1? And you have to look very closely. And if you look up in V1, you can see that there are 2 notches, okay? And that this is actually atrial activity with 2-to-1 conduction. The atrial rate's about 190, so it fits in the range of an atrial tachycardia. If you look over here, you should be able to see a P wave if you saw one here, but you really don't see a P wave at all in these leads. You don't see any P wave over here. So you have to look very carefully at all the leads to pick it out. Again, on your printout, it's probably too small to see, but if we go to the next lead, you can see that I've got arrows, and you can see that there are extra notches here. And that's where you have to look. You have to look for that extra notch in the ST segment, match it up there, see that it's related in a constant fashion, then it marches out. And the history, somebody's doing well, now has a tachycardia or a faster heart rate, isn't doing well, should make you think that this is some sort of atrial arrhythmia because of the history. So that may be the first time I've ever got the lowest percentage was the right answer. But okay, I told you I wasn't going to be popular after these. So okay, an 82-year-old man is found unconscious in the hospital lobby. A rhythm strip is shown. And the tracing most likely represents ventricular lead fracture, electrolyte imbalance of some type, pacemaker battery depletion, ventricular oversensing, or digoxin toxicity. And in this one, I think we can start the clock. Okay, well, at least most people got it right again. Or the majority of people, or the plurality of people, I guess, got it right. So let's look at the tracing. Okay, so obviously this is a paced recording, and we see both atrial and ventricular pacing spikes. And for most of the duration, we have a pacing spike preceding each QRS. The one thing you'll note, though, is that the QRS is very wide. I mean, this is a very wide QRS. And you also will note, if you look at it, that there seems to be some delay between the onset of the pacing spike and the start of the QRS. It looks particularly prominent here, but even up here, you see that the pacing spike doesn't have a sharp takeoff. When you see that, you should think something is poisoning the heart. And it can be seen with drugs, so that this could be somebody with drug toxicity. The other thing is hyperkalemia. You then go out here and you see that you lose, and you really can't see atrial activity, but there's always a P wave, and so I can't really comment much about atrial activity. But out here we see that we have a ventricular pacing spike, there's an atrial spike and a ventricular pacing spike, and loss of capture. And then we go back to the previous pattern. And so what we have here is a very wide QRS complex and loss of capture. And so we'll look at one of those, which of those tracings is going to give us, or which of these answers is going to give us that. Well, digoxin toxicity actually enhances automaticity and excitability, so it doesn't cause you to lose capture. It's not oversensing because there's a pacing spike. The battery, I guess, could be running out, but usually this is not the pattern of battery depletion with a pacemaker. It usually goes to a fixed rate. Ventricular lead fracture wouldn't give you this very wide QRS complex, even though you can have intermittent loss of capture. But remember, you would actually not see a pacing spike if the lead was broken. So you'd see sensing problems, and you wouldn't see a pacing spike. So of these, electrolyte imbalance, or if I had said drug toxicity, that would have been the answer. And this, in fact, this is the classic paced ECG associated with hyperkalemia. Marked QRS widening, some delay between the onset of the pacing spike and the QRS, and loss of capture. And here we see that the potassium in this particular patient was 7.9. He had missed 2 dialysis sessions, and so passed out in the hospital lobby when his K got that high. So again, something you should think about. You have to put all the stuff together when you go through it. Okay. So our next one's a 53-year-old woman with no prior history who presents to the emergency room with recurrent near syncope. Her initial ECG is shown. She is severely intoxicated and has a history of chronic alcohol abuse. There's her standard 12-lead cardiogram. And which of the following would you recommend? Electrolyte repletion, coronary angiography, isoproterenol, amiodarone, genetic testing. And we can start the clock. Dr. Perillo always tells me people get the electrolyte imbalances all the time, and that's most of the people got it. So what are we seeing here? Well, this is T-wave alternans. So let's look at the rhythm. The rhythm is sinus rhythm. The QRS is relatively narrow. The dramatic thing is that we have QT interval prolongation with alternans in the amplitude of the T-wave. And that's a marker of a severe abnormality in repolarization. And then you have to put that together with the history of what she has. 53 years old. Can I use the other language pointer? Sure. Okay. Is that better? Okay. So we go through the history, alcoholic, intoxicated. In fact, if you look in the literature, the time this is most commonly described is in people with recurrent vomiting in the setting of alcoholic hepatitis. It's a mixed electrolyte problem. It's usually deficiencies of intracellular potassium, total body magnesium, and total body calcium. So you have to actually replete everything. The numbers themselves will usually be quite low, but this, when you see this, T-wave alternans, QT prolongation, the appropriate history, always think electrolyte repletion, and that's what most of the people did. You could, again, remember I said you can get the same cardiogram in two conditions. If this was a 17-year-old teenager with recurrent syncope who'd felt well and has 3 siblings who died in their sleep, you might think of QT prolongation, but the history is what tells you what this is likely to be, and that's what you'd recommend. Okay, so there's the T-wave alternans. You can see that. It's pretty dramatic. You can see it in multiple leads. Speeding this up, obviously she has a fast heart rate already, and that's in fact what's keeping her going, is that she doesn't slow down. If you slowed this person down, you might make things much, much worse. Okay, 17-year-old high school tennis player faints during a match on a hot day. Her initial ECG in the emergency room 20 minutes later is shown. She's now conscious and has a systolic blood pressure of 120 after hydration. There's the cardiogram. Which of the following would you recommend? Adenosine, diltiazem, amiodarone, procanamide, DC shock. We're going to make 40%, right, for one of these? Okay, so the right answer is procanamide. So what's the rhythm? 17-year-old tennis player, wide complex but irregular tachycardia. Notice that it's not perfectly regular, and there's changes in the QRS morphology. So that means it's very unlikely to be ventricular. The QRS is very bizarre. So it's very unlikely to be a bundle branch block, particularly in a 17-year-old, and it's absolutely typical for an accessory pathway, for a pre-excited rhythm. So this is pre-excited atrial fibrillation. So we have the two things, and our choices are Well, diltiazem is not going to help and may lower the blood pressure. Adenosine actually may make this worse because it shortens the refractory periods of accessory pathway. You could shock her, but her blood pressure is 120, so it would be nice to avoid shocking her because you'd have to anesthetize her. And you could use amiodarone, and that would take 2 or 3 days to work. But procainamide is effective in accessory pathways, somewhat effective in atrial fibrillation, and in fact, giving procainamide is likely to either slow the rate, shift the conduction off the accessory pathway, and may or may not convert the atrial fibrillation. So the prescribed treatment for this would be procainamide. So the key thing is to recognize that this is pre-excited atrial fibrillation and that the patient is stable. If the patient was unstable, if I gave you the blood pressure was 80 and she was complaining of chest pain or fainted every time she sat up, you'd shock her. But in the absence of that, you put it together and you try the less invasive approach. Always on a board, you try a less invasive approach if it's equally effective. So in this case, you give procainamide, and you may convert the AF, and you should slow conduction over the accessory pathway. Yeah, and Dr. Perillo is reminding me that this is a very common board question. There's all sorts of variety of pre-excited atrial fibrillation. This one is mostly pre-excited, but the key things are the variability in the QRS morphology and the fact that it's irregularly irregular. If this was dead-on regular, it becomes much more of a problem, but it's clearly you've got to look for these minor irregularities. Okay. 53-year-old man underwent emergency placement of an LAD stent 90 minutes into an ST segment elevation MI. 3 days later, the following rhythm strip is obtained. And this is the rhythm strip. And so we can start the clock. Would put an ICD in this guy, coronary angiography, EP study, amiodarone, or just continue routine care? Excellent. So most of you recognize that this is an artifact. And so you continue routine care. And how do you know that? Well, what you have to do is you have to see that there's something that's marching through the tracing that isn't related to these other things. And in fact, you can see that. And when you see intervals like this, you can't have two QRSs 30 milliseconds or 60 milliseconds apart. It's just impossible. But if you march this out, he is a little tachycardic. His heart rate is 110. But those are the QRSs. This other stuff was him, and I don't know whether he was brushing his teeth or scratching his electrode or what he was doing, but this was thought to be a rapid ventricular tachycardia, and it actually was an artifact. It's interesting that there is some literature on this in that about 5 to 10% of referrals to electrophysiologists are for artifacts. So again, it is something that you want to be aware of, something that people on the boards like to put on there because it's something you should know, and it's something where you can definitely harm a patient if you don't recognize it. So when you see a rhythm strip tracing, think artifact. Okay, an 81-year-old man is admitted to the floor with pneumonia, a decreased level of consciousness, and a temperature of 39. He'd received an ICD 8 months ago because of a low ejection fraction and a prior MI. 6 hours after admission, his family reports that he jumped in the bed several times and moaned. On exam, he is tachycardic and diaphoretic, but has a systolic blood pressure of 130. You interrogate his ICD, and this tracing was obtained. Dr. Perillo always tells me it's not legal for me to put interrogations on, but occasionally I have to. So would you change his VF detection zone? Would you turn the ICD detection off? Would you turn the ICD detection off and transfer him to the ICU? Would you add anti-tachycardia pacing? Or would you just continue routine care? And I've labeled for you the atrial tracing, the ventricular tracing. These are so-called marker channels. So we can start the clock. Okay, well, the correct answer is 3. Dr. Perillo had a nice paper this year about the complications of patients in intensive care units who develop atrial fibrillation. And as I recall, it prolonged hospital stay by about 100%, Joe, is that correct? It was, yeah. And it's really striking, if you go into atrial fibrillation, how fast you can go, even if you're 82. I was monitoring a study, and we saw all these people with heart rates of 210, 220, 230, because their temperature was 39, and they went into atrial fibrillation. Well, so let's look at the tracing and see what's going on. The top tracing is the atrium, and it's very disorganized and very rapid, consistent with atrial fibrillation. The next tracing is the ventricle. It's